Muy buenos días a todos. Sean bienvenidos a esta sesión de las reuniones clínicas médicas RCM de la Facultad de Medicina de la UPB. Mi nombre es Claudia Elena Villegas Estelies. Para mí es un gusto saludarlos en esta mañana y también darle la bienvenida a nuestro invitado especial. Me gustaría que lo conocieran. Él, de igual forma, también ha sido nuestro invitado especial en otras sesiones y es profesor no solamente de la Universidad de la Ciudad de Nueva York, como enseguida vamos a ver, sino que también es profesor nuestro en la Facultad de Medicina de la Universidad Pontificia Bolivariana. Él es el doctor José Fernando Flores Arango. El doctor José Fernando es médico y cirujano de la Universidad de Antioquia, magíster en ciencias básicas biomédicas, tiene un doctorado en informática en salud, es profesor asociado de la Escuela de Salud Pública de la Universidad de la Ciudad de Nueva York, como les acabo de mencionar, en los Estados Unidos, y además es docente cátedra de la Universidad Pontificia Bolivariana. En esta mañana le damos la bienvenida al doctor con un tema que es de sumo interés. También entonces esperamos que ustedes hagan sus comentarios, sus preguntas en el chat de la sesión, las cuales trataremos al final. El canal YouTube Saludable de la UPB. Quedará entonces disponible en el canal YouTube Saludable de la UPB. En el día de hoy, doctor José Fernando, bienvenido con el tema Big Data, a World of Possibilities. Es para nosotros un honor tenerte nuevamente como invitado y también agradecemos a las personas que en este momento se conectan y están en transmisión con nosotros. Para todos, un feliz día. Bienvenido, José. Adelante.
Bueno, muchas gracias. Muchas gracias por la invitación. Siempre es un placer compartir con ustedes estas experiencias. Veo que tenemos 82 participantes. No sé quiénes estuvieron de estos 82 en la conferencia o en el otro RCM que tuvimos de Futuro de la Medicina. De pronto, si levantamos la mano ahí los que estuvieron, solo para tener como una idea más o menos porcentual de cuántos me han escuchado parte del cuento. Entonces veo que Claudia levantó la mano y no veo otros que hayan levantado la mano. No, y lo pregunto es para saber cómo hago la aproximación. Lo otro es que Claudia me pidió que si podía hacer la conferencia en inglés. Sería un placer, pero quiero saber si todo mundo, o sea, si la mayoría están cómodos en que la presentación la haga la parte oral en inglés, a pesar de que las diapositivas van a estar en español, para que tengamos ese ejercicio. Si de pronto, entonces voy a empezar en esa forma, y si de pronto vamos muy rápido o tenemos algún inconveniente o no están siguiéndome, pues simplemente me hacen una ceñita y con mucho gusto le bajamos el ritmo y pasamos a español, no hay ningún problema. Entonces, cuando nosotros hablamos de we talk about big data in healthcare, we can talk about a world of possibilities, o un mundo de posibilidades. The way that I want to present this today is going to be in four parts. The first one is to talk about, a little bit about the context, the environment, why we are talking about big data and what that means to us nowadays. Then we are going to go and see some basic concepts. Some of these I have presented before. That's why I was asking how much people has attended my conference previously, because in some way it's going to be a little bit of going over things that we have presented before, but I think it's really important for those that has not attended, and even if you have attended, to review that. We are going to be talking about what is going on today and what is going to be the future. Any questions so far? ¿Alguna pregunta hasta ahora?
Not yet.
Okay.
Go ahead.
Then let's start with the context. This context comes when we talk about big data. I really want to go back into the concept of informatics cascade. Um, the first thing is we use our senses, we use a lot of instruments, we use a lot of measurement tools to interact with the world. And that interaction with the world creates something that we call data. And we are receiving data all the time. Our brains are exposed to data through the eyes, through the ears, through the taste, through the touch. We have all our senses that are basically the interfaces with the world. And every single thing that comes through our senses, we can consider that data. But also, those stimuli and those elements that are coming through our senses, we can have instruments or we can have elements to capture that and to store that and to preserve that because, as you know, our brain is really limited in storing or having memory. But the important thing is when we are talking about informatics, it's not just about the data, but it's how we take that data and give some meaning. But the interesting thing here is meaning is not given by itself when you have data. And the traditional example that I use is when I told you 120/80. When I say 120/80, the common thing that gets activated in our brains is the normal values of the blood pressure of an adult person or of adult human.
Y luego que nadie sepa quién soy yo. Ni
Sí,
dónde
pero sí
trabajo.
sabemos que eso es vos.
Sorry.
That's okay. Uh,
Turn off your microphone, Pipe. Thank you.
yeah, no, then that's the classic example. But the thing is, if you present that 120/80 to other different publics, it can mean the specification of a tire, it could be the number of a house, it could be an address, it could be a set of coordinates. It can have so many meanings. But just when we provide meaning to that data that we're observing is when we have information. And that information requires an interpretation, and that interpretation applied in a specific ways what is going to be called knowledge. And in that regard, that 120/80 plus additional data, additional information is going to have a complete different meaning. Because if I tell you that that 120/80 is a 5-year-old kid, then the reference framework is completely different. And now we can say that, hey, that kid has a high blood pressure. Or if that 120/80 is relating to an individual that is under a medication for high blood pressure and you are seeing 120/80, maybe you can say, hey, this is a person that is under control and he was hypertensive. Or maybe if you are not taking medications and is expected to have a higher blood pressure, is having a low pressure. And then we use that knowledge, we use this information, we use the data to make decisions as what we call wisdom. Then in which context are we going to be talking today? We're talking today in that cascade. Even though we are talking about big data, we are talking is how we take this data and what makes this data big in order to create this cascade, be able to have information, create knowledge, and be able to make decisions. In that order of ideas, we need to think that data has a series of processes. And the first thing is we need to capture that. I told you that the natural way of doing that is through our senses. Uh, but that's not enough because we are going to forget easily. Then to avoid forgetting, we need to store that data that we have captured with our senses or with some instruments in some way. We can storage data in clay, we can storage data tying notes, we can storage data writing and creating computer programs anyway. But once you store the data, we need to take care of that storage mean because things can degrade. And some of you even didn't were exposed to the cassette. and some of you don't even get exposed to the CDs and the DVDs. And if we think about electronic data, the storage time of electronic means is around 10 to 15 years. A CD and DVD can start degrading after that time, and the SD cards, the flash memories, these things can degrade even earlier because the way that they store the data, it's not as good as, for example, as paper and ink, that we have evidence of storage over 5,000 years. Then that's something that we need to think, because, hey, yes, we are storing that, but how we are protecting that to avoid being loose. We can also transport data, and on the when we have physical storage, then we need to move things physically. But when we have electronic information, we can transfer that electronically. And then now we are talking about bandwidth, and we are talking about other elements. We need to be able to search. And once we search, then we retrieve what we have searched. And I think some of you have experienced that you search something in PubMed, but being able to search, it doesn't mean that you can access it, because it's going to tell you, oh yes, the thing that you're looking is in this journal, but then when you try to obtain that, you need to pay for that. Then we can transform that data in something that we can use in a different way or differentiation. Then we can do analysis. We can create visualizations, we can update the data, and then we can use this to capture and continue the cycle. Then in this context is that we are going to be thinking in big data. We are not talking in big data just in the capture or just in the analysis, even though are going to be making a huge emphasis in the analysis, visualization, and update, because it's the easiest way to understand the big data. But we need to understand that big data, when we talk about that, we need to talk about the whole data process, because it's not independent. And talking about big data in the context of health informatics, we see that we are generating data from molecules, cells, organs, signals, individuals, organizations, government, payers, communities. We have a lot of data sources. And that's something that is challenging in healthcare. Because we need to organize this in some way that is useful. And as you see, we have a lot of information systems or data collection or data processing systems that are going to be generating a lot of elements. And then we need to think that healthcare has changed, and it has been changing for years. And we can talk about that we are facing the era of the health 4.0. And 4.0 is not that the route of the delivery has changed, but the way that we deliver healthcare has changed. And when we talk about healthcare version 1, that's the traditional way that we approach to medical and healthcare delivery. And the service usually is reactive. What does it mean? I get sick, I go to the doctor. That's the traditional way of approaching healthcare. And that scenario, the environment where we provide those services is the home, in the outpatient office, in the hospital, or the lab. Those has been the traditional and the standard of care for healthcare delivery. And most of the things that we study in medical school, most of the things that we do as physicians are centered in this paradigm, in the paradigm of the disease. That somebody is sick, then we need to make it right or avoid getting worse. Documentation used to be on paper. The communication was direct. You went to the doctor, you went to the nurse, you talk with them, you ask the questions, you have the answers. And the relationships used to be direct as well. There was a time that we didn't have insurance companies, we didn't have the EPSs, we didn't have a mediation in that relationship that we have with the healthcare services. And the diagnosis and treatment was physician-centric because as physicians, we used to have the power, we used to have the knowledge. And this is something that some of us as teachers still believe that is true. And I want to call here for a reality check because when we are talking about the amount of data that we are generating in healthcare, in a single week, in a specialty like gastroenterology, for example, that is not a big specialty because there is kind of limitation of what we can talk about the 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 the, the gastrointestinal tract and their diseases. You need 16 years to read what is produced in 1 week. Then don't talk about pediatrics, don't talk about internal medicine, don't talk about OB-GYN, obstetrics and gynecology. We are going to need hundreds of years to be able to cover whole data, whole knowledge that is being produced per week. And then even if we are specialized, we cannot think that we have the knowledge and we have all the tools to really do a proper diagnosis and treatment. There are different things that are out there. Then when we jump to the second generation of the second version of healthcare is when we start talking about the preventive medicine. And then we start having a different new scenarios. We have the community, we have the pre-hospitals, then we have the brigades, we have the the EMS services, the emergency medical services. And we start talking about electronic medical records, or at least the documentation about that clinical encounter center on the relationship between the patient and the physicians. And this is kind of related, that communication start having the email, and then we have a relationship that is mediated by the insurance companies or third parties. And that was a paradigm that we have about evidence-based medicine, that if we want to apply our knowledge, then we follow the best evidence available. But when you study evidence-based medicine, you are going to find that usually recommendations are kind of lukewarm. They are not really definitive against or in favor. Sometimes they are in between or kneeling towards favorable or kneeling towards against the recommendation. But usually that is really hard to find evidence that is strong in one direction. And that's something that also has biased our decision-making process, because sometimes we just follow the recommendations without being critical of what the evidence is telling us. Now we have the Health 3.0 that we incorporate promotion in the healthcare, and the scenario is distributed because you move around all these scenarios. And we have a technology for documentation that is called the personal health record. The personal health record is when you provide your own data. Patients with diabetes that have been monitored all the time, the patients with cardiac failure, with heart failure, that they weigh themselves every single day, the patients with peritoneal dialysis that can monitor their products, all these chronic patients that we can track and be part of the healthcare are generating personal health records, but also those that are healthy and having healthy behavior, and we are documenting that data. They are producing personal health records. When you have a Fitbit, when you have your Apple Watch, when you have your phone to register your physical activity, or you are counting calories, or you are documenting your healthy habits, you are generating your own personal health record. And now we are facing that the communication is not only direct, we have the email, but now we have instant messaging, we have WhatsApp, we have intrusive means to be communicating. And now we are not only talking about insurance, but we are talking about something that is network of services, and how they are really, really an interrelationship of a lot of organizations and a lot of services. And this is in response of ultra specialization. And then we are in the decision-making process of diagnosis and treatment, we start seeing this technology that is called clinical decision support systems that are basically cognitive aids to help us to make better decisions. And the Health 4.0 is where the service is participative and predictive. The patient has an active role in the healthcare, And even sometimes the patients are going to be demanding some kind of services. The scenario is ubiquitous. In every single place, we can be delivering health. As you see, now we are not talking about the disease, but we are how we maintain the health, and now we talk about the electronic health record, the record that comes that register that aggregates the medical record, the personal record, and different sources of information about your health into a single place. And then you can see how this is a complex information system that is part of the thing that the new law in Colombia is aiming to have. That that unified electronic health record is towards something that we want to have this. And the communication now is mediated. Now you don't communicate directly with anybody. You don't communicate with technologies. We are communicating with chatbots. We are communicating with computers that are able to answer the most common questions. And the relationship now of the patient is not with the physician, is not only with the physician, it's not just with the insurance, it's not in that network, but we have what is called medical systems, and there is a new concept there that is the learning enterprise, and how we can learn in the way that we deliver a healthcare system and be able to adapt in the way that we are delivering health and be able to keep populations within some goals and outcomes. And now the diagnosis and treatment, we are talking about clinical agents. We are talking about artificial intelligence. And if you have been following the news lately, people is kind of having these ethical discussions in art production. Is creativity gone? What is going to happen with artists? And the same is going to happen with healthcare. When we start seeing more and more artificial intelligent agents that are going to be able to do diagnosis and treatment in a more and faster way, precise way, and safe way than physicians, then what is going to be the ethical discussions and what are going to be there? And in that order of ideas, you see that we are producing a big volume, a big amount of data in healthcare because it's coming from a variety of sources, multiple sources, in a speed that is really difficult to catch up. And there is a lot of variability in the type of data that we are using. When we have data that behave in that way, we are talking about big data. Then basically we are living in the era of big data. Wherever you look, we are talking about big data because as I try to depict you, with the evolution of the way that we are delivering healthcare systems, we cannot talk of healthcare delivery without thinking that we need to be dealing with big data. We need to be dealing with high volume, high velocity, high variability, and a diverse collection of sources. And in that regard, and if you remember that cycle that we're depicting you, we need to deal with how we are going to capture, store, curate, transport, transform, search, retrieve, all these data that we are creating. What is that going to be located? How we can access that? How we can interoperate? How we can communicate? And those are the big challenges that we have. And if we want to think about big data is here in the center of intersection of three big disciplines. The first one is what we know as data science. The data science traditionally has been dealing with creating the descriptive statistics or dealing with the statistics, but data science also deals with predictive modeling. And a predictive modeling is when you have, or you can read, hey, there is a logistic regression there, or there is a formula that we can apply to predict a risk, for example, Framingham. That's a predictive modeling that was created from an observation of a cohort of patients, and they were able to adjust some weights to different variables and create a predictive modeling. In We also have another discipline that is the BI, the business intelligence, inteligencia de negocios. And BI, it's a discipline that is basically oriented to how we create reports, how we do multidimensional analysis. And what is that? Uh, that we have, for example, gender, and we have a diagnosis, and then we want to compare how things behave in those multiple dimensions and how multiple variables interact, and a little bit further than that, the descriptive statistics. And there is a concept there that is called the cubes, where you can manipulate the way that you are visualizing the data or how you organize the data in order to try to discover new relationships. Uh, and we also have the other discipline, that's the artificial intelligence on the right, that basically is something that we call the mature learning, or the computer learning. That is basically how computers, not only computers, software, can behave like they were intelligent. And we can create computer programs to solve specific problems that we want. And then in that regard, there are different techniques, and you can see that all these things are going to be intersecting, and we are going to see that we have multiple methods. But definitely BI, big data, is in the center of all this. When we are talking about big data, we are talking about data sciences, we are talking about business intelligence, we are talking about artificial intelligence applied in some way that we can create proper data management and proper big data management. Challenges are so big. In that regards, then let's go and see how we come here. And I have showed this how technologies has been growing really fast. But think about this. Internet came into market in 1993. Cell phones came in the same year. Smartphones appeared in 2008 and tablets in 2010. And as you see, these adoption curves are basically skyrocketing. This is telling us that technology is embedded in our world. And if we look into the mobile subscriptions for 100 people in Colombia, we have 132 subscriptions for every 100 people. That means 1.32 cell phones per person in Colombia. And it's even higher than in China, United States. It's way above the average of the world. And the that is telling us, hey, there is a lot of opportunity and a lot of data that is being generated, because you are actively generating data when you have a cell phone, or when you are carrying a cell phone. It doesn't mean that you have access, that everybody has access. And the other thing, when they ask in Colombia about the share of the population using internet, it's surprising that we have only around 67, 69% of population that has a shared internet. But this is the way that the question was asked, because people doesn't identify that using smartphones, using cell phones, actually you are using internet. People don't think that social networks is internet. People don't think that those interactions are part of the interactions in health. And the other thing that we are not realizing is mental health is a big issue that has been depicted by that has been developed by all the things, especially what happened with COVID and when we started retrieving the people out. If we want to think about what is going on internet in healthcare, this is a little video that is going to give us some information about what happened 5 years ago. I'm sorry, it didn't play. Let me go back. Then if you look, those numbers are from some years ago, but if we look what happened last year, we can see that those numbers are growing and growing and growing. And the apps downloaded, almost a quarter of the apps downloaded are healthcare related. A lot of people is expressing their feelings and expressing the health conditions in all social media, then Instagram, Twitter, Facebook. They are sources to look into something that we call sentiment analysis and is try to explore how the people is feeling, what they're saying about their healthcare, how they are feeling about their medications, they're having adverse events. There is a lot of things that are having there. And WhatsApp, Messenger, there is a lot of data that is being transmitted there. And even in TikTok, we are start seeing healthcare content and people talking about this thing. There is a revolution out there, and this is only 60 seconds. In 60 seconds, that's 1 minute. This is what's going on internet. Those are huge numbers, and they are growing every single year. And a chunk of this, as we saw in the previous video as well, is going to be healthcare. Is going to be healthcare related. Then let's see what's going on, and let's approach big data from the point of view of analytics. And this is a paper that you can refer about big data at the dawn of healthcare new age. And it was published 7 years ago, and we are still not there, but this is something that we need to keep thinking about, and new technology is going to come and new approaches are going to come. Then we have the first generation of analytics in big data. Then we are going to have data from the electronic health record, the electronic medical health record, that is going to allow us to build something that is called data marts. Those data marts are a collection of people that we de-identify then in order to protect their privacy, but we are able to inquire about efficacy of medications, efficacy of treatments, efficacy of models of services. We can a traditional data mart that you actually interacted, I'm pretty sure, is when you look into the COVID maps around the world and how COVID was being spread. That's actually a visualization that is coming from a data mart. A data mart is a collection of multiple sources that are normalized, and then we can do things with that as creating those maps. Um, Performance measurements is one of those big data analytics that we can do, and is how often an institution, an organization is having complications, or an individual as provider, and how often we consider that is a failure of treatment. For example, if patients comes back to the hospital, or they need to be put in a different medication or a different treatment because the one that we provided was not enough. We can have the multidimensional cubes that are those things that I was describing as different things that we can manipulate. We can have dashboards where we see indicators and be able to make decisions. And in this regards, the big data is going to help us to create clinical alerts and reminders, and being proactive in the way that we are going to be interacting. There is a problem with some of this, and there is a tableau effect. The tableau effect is that when we start using these analytics, there is so much that you can do, but you don't gain new knowledge or new elements from this. And the other thing is, could start generating a lot of isolated data sources that are not really well connected, and then you can start seeing contradicting information when you have that proliferation or this growth of data sources that are not really well aligned. Sometimes the access to this type of analytics is limited. Sometimes the filtering of data is going to be a problem because we cannot have the granularity of observations, and then there are going to be some biases in the interpretation that we have. When we are in the context of clinical alerts and reminders, if we don't design that properly, we are going to have something that is alert fatigue. Alert fatigue is that things just keep coming and you just ignore them because, hey, this is trash. And the day that you need to pay attention to something, you just ignore the thing that you really need to pay attention. And we are experienced people that is having overload of information. Then we need to be able to create better ways of presenting these analytics, this visualization, and be able to deliver better representations of better ways of doing this. And also there are studies that has demonstrated that definitely when you have this overload of information, the providers, the people get distracted from the main task. Then we need to be careful because we can be overwhelmed for all these things that are coming to us and not be really efficient. And at the end, if you have a distracted provider, we have this adverse event that we are not delivering the healthcare that we want to deliver, and we can have more problems instead of solving them. And that's a reality that can happen with all these fancy things because you get distracted into the woods and you are not able to see the tree out of the forest. The second generation of big data is when we have consolidated data or we have linked sources. And that's something that a World Organization did really well for the COVID pandemic. Then they decide, okay, we are going to organize this data and we are going to be the we are going to consolidate the data. We are going to be the link, we are providing the linkage, and then everybody can refer this as the standard reference model. In that second generation, there are improvements in the way that we visualize data, and we move the visualization from the desktop uh, of the analyst to the web, and we made that public. Then basically the example of having a second generation data visualization analytics tool are those dashboard, those maps that we saw about COVID. And also in this level of analytics, we have search engines that are going to be able to retrieve data from multiple sources and be able to aggregate them. Now the big questions in second generation is how we can impact the productivity, how we can be efficient in some way in using this data and apply that for the day-to-day basis. There are concerns about the workload that the people is experiencing. And if you read, for example, about clinical decision support systems, if you read about documentation in electronic forms, there is a lot of concerns about the increase of workload of the healthcare providers with the scenario when we put technology there. Then there's a lot of things that we need to be doing there in order to be able to reduce that. And we also are seeing a lot of indexes and a lot of measurements that are out there, and then which is going to be the right one? What is the one that I'm going to be paying attention? Which should be the one that I need to take into account? And then now again, we need to put a feedback in the cycle and try to think how the same big data methods or the artificial intelligence methods or the computer science methods are going to help us to filter them and do better presentation of the data. And the third generation is basically when we go from that business intelligence that is based on the desktop, and we are able to democratize the information. We allow people to explore data, to navigate data, and we can have a high-level analytics or advanced analytics where we can create a high-level modeling, and we can evaluate actually healthcare delivery programs through that analytic. We can create predictive models, and we have been working on that at the school. For those that you don't know, we have a project called ADA, Herramientas de Asistencia al Diagnóstico Antenatal. There's a collection of tools that are driven by artificial intelligence to help in the prenatal control and predict high-risk pregnancy and be able to derive patients to the proper care. And even the system is able to recommend some interventions for people that maybe they are not aware, and those are that's type of things that we are doing. And having a platform independency and being able to have population analytics is going to be this third level. And really important is to be able to have that analytic in the workflow, because nowadays, basically you have a question and then you need to go to a secondary source in order to try to do the analytic, but they are not really integrated. Then this is the recount about what big data is. As you see, it's not as mysterious as it sounds. It's more about how we really deal with that volume, with that speed, and we are able to deliver timely information or timely data that can be used as an information to decision makers. Then let's see some examples that are going on today. And this is a Smart Rapid Tracker. This is a product created by one of my colleagues here in the City University of New York that is using the WHO information or data about COVID, and they have created interesting visualization tools. I encourage you to visit this. I'm going to give you the link, and you can go and see different dashboards, these different visualizations, different ways of exploring data. And this is updated basically every day. As you see, this was updated 22nd of August 22, 21st of August 22, and the 24th of August 22. Then the opportunity of data here is kind of really high. And this is an example of things that we will be seeing in the future. Now that right now I'm going to an event that is the Pandemic Response Institute of the City of New York, and there is going to be something like this for monkeypox. There is going to be something like this for car accidents and things like that. And we need to be able to track public health events on real time and be able to make decisions and evaluate interventions and see if things are working or not. Here is our national information system, the CISPRO, el Sistema Integral de la Información de la Protección Social. It's really interesting. It has some indicators, but it's a little bit concerning of the opportunity of data that we have in Colombia. Then vaccinations, we have an opportunity of 2 years. The information about main indicators like the weight of birth of kids, it's a little bit over a year. The same about the quality of service of delivery of care is over a year, and the number of beds available is over 2 years. But the good thing is if you go to catalogs and you go to digital services, you can be able to access this data in an open way. And you can do your own explorations, you can do your own indicators, you can create your own dashboards. And the aim and the hope is that with the new regulation about interoperability, the new regulation about the unified electronic health record, we have a better opportunity of this data, because it's really difficult to make decisions when we don't have just in time information. This is the Civigila, and this is the notification for last week of the events that are mandatory to be notified. Um, this is a really useful tool that can give us a better understanding of the dynamic of those things that are mandatory to report and surveillance. And it has really interesting tools. And this is an example of big data about a unexpected behavior, for example, then you can see outbreaks out from the data and then say, hey, something is happening. And just exploring yesterday, they expect two events of snake bites per week in Boyacá. And last week, they have 4 events in a single day. Then basically, what's going on? Are the snakes waking up or what? Then, but being able to survey those things, being able to create alerts about that, are going to help us to create other questions. The thing is, we cannot be surveilling every single thing. Then how we create really good tools in order to be able to look into that information and generate the alerts and the alarms for the people that needs to receive that data in order to make decisions. Then what is the future? The future definitely is that as healthcare is progressing, web is progressing, and now we are going to be seeing things like they are not only data marts, but something that are called the semantic databases. Semantic databases are things that they store representations of knowledge in some way that you can create relationship between their concepts. It's not just like an Excel table. It's something a little bit more complex, but definitely that's going to be happening because we are having all this amount of data that are originated by the mobiles, and we can be able to predict the present, to have snapshots of what is going on or what is going to be, when is going to be the next event that we need to be prepared for. And then we are going to see distributed searches, not anymore just focus, and the meta searches are going to be more important because they are going to be crawlers that are going to be bringing those search and bringing that, and of course more and more intelligent agents for everything. We are going to see artificial intelligence everywhere. We are seeing that even though we don't know or we don't notice, but definitely that's going to be changing, and that's the new tendency. Also, in healthcare, what is going to be the future? Traditional way is that we have services, and those services were based in infrastructure and other support systems. And sometimes the services, that infrastructure and that support generate knowledge. But in nowadays, we need to think that a healthcare system, in the context of the learning environment, the learning enterprise, we need to have the knowledge not as a product, but the knowledge as a core that is going to be informing the basic operation, that is going to be informing the health delivery, and is going to be informing the need and the way that we adopt or use the support systems. And this is going to be only possible because big data, artificial intelligence, and computer science. This requires a revisit of the way that we understand a healthcare delivery, because we don't want to have a service base, but we are going to be able to do a better service based on knowledge, not just trying to collect money or to try to survive, or but how we provide those services with the best knowledge available. And that then gives us to the introduction of the concept that is about precision health, but with big data. And when we have proactive patients that are no more than the physician sometimes, when we have preventive care, when we have participative care because the decision making is short, and we want to have precision or personalized delivery, at the end, the concept of evidence-based medicine, the concept of clinical trials, the concept of cohorts, maybe is going to be, needs to be rethink, because when you start adding variables, basically experiments are going to be the n equals 1. And this is the precision health, because a single variable that changes in your profile, in your digital twin, that is one of these concepts that we are talking right now, is going to change completely. The intervention is going to be change the probability of success, is going to change everything. Then this is something that we need to think about, and the future of medicine, we cannot conceive it with the help of agents, with the help of big data, but we need to highlight it's something that computers cannot replace yet, and is that human touch. Is that we are going to looking into the eyes, and we are going to be looking into the soul of those patients. We are going to be able to connect with them, and that touch is something that we need to exercise. And remember that we cure sometimes, we alleviate others, but we comfort always. And that's something that no technology is going to take us away. And don't go into the trap of just following blindly the technology, but remember that you have a higher purpose that just being a referral tool or just being an operator of a computer, because being physician, being a nurse is more than that. With that, then I think that I give you a context, a recount, what is going on, what is going to be the future, and thank you very much for your attention. We have 2 minutes for questions.
Don't worry, if you need more time for questions,
Y las podemos hacer.
go ahead. Congratulations! Such a great conference, Dr. Flores. We're so pleased to have you today as our guest. Thank you so much. Muchísimas gracias y quiero felicitar al doctor José Fernando por la excelente conferencia que nos ha traído en el día de hoy, tan importante y pertinente para nuestra formación como médicos, para nuestro ejercicio profesional en ciencias de la salud. Y es de verdad nuevamente un gusto escucharte, es un honor tenerte como invitado. Y quisiera en este momento precisamente abrir la sesión de las preguntas, comentarios por parte de nuestros invitados, nuestros asistentes, quienes deseen en este momento activar sus micrófonos o anotar alguna pregunta para el doctor José Fernando en el chat son bienvenidos. Adelante.
Gracias, Santiago. Y perdimos gente, solo veo 58.
Algunos han salido por acá. Tenemos por acá de parte de la doctora Diana Paola. Voy entonces a leer el comentario que en este momento hace en el chat. Gracias, doctor Flores, por la conferencia y plantear este panorama actual del Big Data. Un saludo especial. Agradezco su opinión frente a estas preguntas. Voy a leerlas a continuación. ¿Cómo se ha gestionado en otros países la privacidad del paciente en la integración electrónica de la historia clínica? Hay datos muy sensibles que van más allá de la identificación personal y que se pudieran acceder desde distintas fuentes o sistemas a partir de la identificación del paciente.
Bueno, entonces, primero, ¿cómo se gestiona el asunto? El habeas data de Colombia es una herencia del modelo europeo. Y HIPAA en Estados Unidos es un copy-pega adaptado del modelo europeo. Entonces, básicamente, lo que estamos siguiendo nosotros son esos modelos europeos en cuanto a lo que es privacidad del paciente. ¿Cuál es la primera intervención? Están los 17 identificadores que supuestamente cuando uno los remueve se de-identifica una persona, pero en la era del Big Data y de la inteligencia artificial, tenemos que ser sinceros y es una falacia. Con datos incluso que no son identificantes de un individuo, es posible reidentificar personas si yo quisiera hacer la reidentificación con suficiente cantidad de puntos de datos. Y eso da respuesta a la segunda pregunta, si es posible rastrear el paciente en diferentes sistemas para captar sus datos en la identificación personal. Sí, y de hecho, por ejemplo, Estados Unidos, ellos no tienen, aquí no hay un número de identificación nacional. No hay un número común, porque a pesar de que existe el número del seguro social y que existen las licencias de conducción, si yo me muevo de estado, la licencia de conducción cambia. Y el número de seguro social es un número que está prohibido ser usado como identificador en ninguna otra parte que no sea para asuntos financieros, porque puede generar discriminación y otras cosas en el servicio, por ejemplo. En Colombia tenemos una ventaja que tenemos la cédula no es privada, como el seguro social, es un número público. O sea, uno puede ir a cualquier sistema de información, es más, ustedes pueden ir al CISPRO o pueden ir a la pila y consultar la cédula de cualquier colombiano y le dice cuál es la seguridad social y a qué está afiliado. O sea, era un ejercicio que yo hacía con las personas y uno simplemente puede escribir un robot que vaya desde el 000 hasta el 13 billones, que creo que es el último número de cédula que está dentro del sistema, y tratar de recoger el histórico de cuál es la afiliación de seguridad social de los colombianos. O sea, los sistemas son tan seguros como el eslabón más débil que haya, ¿no? Y será un reto siempre a futuro cómo mantener esa privacidad y esa confidencialidad, porque definitivamente seguimos teniendo diagnósticos tabús y seguimos teniendo discriminación por condiciones de salud. Y eso trae unas repercusiones adicionales en lo laboral, en lo de acceso a servicios. O sea, hay una complejidad muy grande y hay una preocupación también cuando tenemos los aseguradores teniendo acceso a la historia clínica de los pacientes y tenemos sistemas integrados como por ejemplo un SURA, donde son EPS pero aseguradores de vida. ¿Cuál es la ética que tiene una compañía como esta? Si no estoy diciendo que ellos lo estén haciendo mal, pero estoy simplemente usando el ejemplo que es una compañía que tiene los dos servicios. Tengo acceso a los datos de salud. ¿Cómo está el potencial de usarse negativamente en el proceso de asegurabilidad? ¿Sí? O en el proceso de oferta de servicios desde la medicina prepagada. Eso genera muchas preguntas y hay muchos inconvenientes alrededor de eso y es una realidad. ¿Qué propuestas hay? Hay propuestas desde, por ejemplo, utilizar conceptos como el blockchain, que es la cadena de bloques, que es lo que se utiliza para las monedas digitales, que si, por ejemplo, uno tuviera el registro de salud de una persona en una cadena, nosotros podemos ver todas las transacciones que se hayan hecho sobre ese registro de salud y hacer eso público y accesible a los pacientes, de tal manera que ellos sean los que puedan controlar el acceso y la autoridad independiente en la cronología. Eso tiene otras implicaciones pues en cuanto al control de acceso y cómo manipular el asunto, porque cuando los datos están allá y cuál es la conciencia de la gente, o sea, va a tener unos retos, pero esa es una forma. Y si ustedes piensan con la carpeta ciudadana en Colombia, olvídense que en Colombia no hay privacidad. Sí, en Colombia no hay privacidad para nada y es una discusión que hay que dar a diferentes niveles y qué es lo que queremos mantener privados y por qué, ¿sí? Pero muy importante es, cuando se tengan los sistemas de información, la auditoría del acceso y el nivel de acceso es fundamental en el diseño de los sistemas de información para poder hacer la gestión. Y es una de las estrategias que más sirve, es tener esa auditoría y la gestión de la auditoría, o sea, hacer la gestión del acceso y el control. ¿Sí? No sé si con eso contesté la pregunta. Y la tercera dice, como epidemiólogo a veces cierta tendencia en las técnicas de Big Data fuera como una caja de Pandora, capta muchos datos de diferentes fuentes y tipos y obtiene el modelo de predicción. Solo por la N obtendrás diferentes modelos estadísticamente que pueden carecer de plausibilidad biológica. Correcto. Las limitaciones, primero, no hay científicos de datos generales. Casi que los científicos de datos tienen que ser expertos del dominio y se convierten en científicos de datos. Entonces, esa es una de las primeras cosas. O sea, lo que tenemos que hacer es tener Y como, como en las pruebas estadísticas, o sea, hay que tener claro que hay unos presunciones y hay unos preceptos que tienen que cumplirse para poder aplicar el concepto. Y es realmente, o sea, las cajas negras existen ahí y no son muy bienvenidas. Y si uno no tiene explicabilidad, y ese es uno de los puntos de investigación más cruciales en informática en salud ahorita, es la explicabilidad de los agentes. O sea, cuando yo tengo un modelo que parece una caja negra, ¿cómo yo logro explicar que realmente es lógico y sensible y, y cómo le transmito eso incluso al usuario final? Que ahí es donde está el asunto. Entonces, sí, Big Data no reemplaza métodos tradicionales. Big Data nos permite explorar datos en diferentes fuentes y utiliza o sea, se basa en estadística y se basa en métodos numéricos tradicionales. Lo que tenemos que hacer evidente es qué es lo que hay debajo para poder tener confianza en lo que está trabajando, porque en realidad cuando no creamos confianza es cuando tenemos la barrera en el asunto. Y es lo mismo, o sea, cuando tenemos la discusión de la P, una P realmente qué significa, o cuando tenemos una discusión alrededor del teorema de Bayes en lo que es detección de señales, una prueba positiva, ¿qué significa? Es que yo tengo la enfermedad, no, es simplemente una probabilidad de que tiene que contrarrestarse, que tiene que contrastarse con la prevalencia en la población de referencia. Pero ¿cuál es mi población de referencia? Y cuando yo voy metiéndole más datos, mi población de referencia empieza a ser más chiquita y la probabilidad empieza a ser diferente. Entonces, no, hay mucho por discutir y definitivamente, sí, no es la panacea. O sea, Big Data no es la panacea. Big Data es más esta discusión académica de qué hacemos con lo que está pasando y cómo en ese proceso, desde la captura hasta la visualización y las conclusiones, cómo manejamos esto, porque hay demasiadas preguntas no contestadas.
Definitivamente es un fenómeno con muchas aristas y creo que la discusión y el análisis da mucha tela que cortar y de acá en adelante yo creo que va a ser muy importante seguir reflexionando en relación a este tema y considero que nos has dado una claridad de conceptos muy importante precisamente para contextualizarnos en lo que es este fenómeno que de verdad tiene unas implicaciones muy grandes. Por acá la doctora Diana Paola, muchas gracias por su respuesta. Evidencia aspectos clave de los problemas éticos como riesgo, discriminación en servicios, entre otros. Expertos del dominio y luego científico de datos, así mejor.
Muchas
Yo creo
gracias por
que
la participación y sé que la gente tiene eh, un montón de cosas que hacer. Qué pena haberles robado 10 minutos, pero creo
no
que
hay problema,
sí, no.
para nada, porque yo creo que
Y
era muy importante este diálogo y esta reflexión que nos has planteado a partir de las preguntas
y
y los cuestionamientos. Dale,
correcto.
José.
Y tienen que estar sintonizados porque vamos a estar allá en la escuela de verano y vamos a tener un tema incluso más candente todavía, que es el cuento de los metaversos y
Metaverso.
las realidades virtuales, que vamos a discutir eso, o sea, ese escenario electrónico de interacción, cómo nos modifica la formación, cómo nos modifica la interacción, sí, entonces que estén sintonizados porque van a haber cosas interesantes que vamos a estar discutiendo.
Totalmente, y te agradezco mucho, José, también por motivar lo que va a ser tu presencia en la escuela de verano Metauniversos de este año 2022 en la Universidad Pontificia Bolivariana. Recuerden que la escuela de verano Saberes UPB se va a llevar a cabo entre el 3 y el 7 de octubre acá en la Universidad Pontificia Bolivariana. El doctor José Fernando Flores va a ser uno de nuestros invitados especiales y vamos a tener la oportunidad de contar con él en diferentes actividades y espacios. Entonces, también que esta sea la oportunidad para invitarlos cordialmente a nuestra Escuela de Verano Saberes UPB Metauniversos en 2022. Doctor José Fernando Flores, muchísimas gracias por ser nuestro invitado especial en el día de hoy. Tenemos muchos mensajes de agradecimiento y resaltando la conferencia, felicitándote por la presentación. Y de nuevo, mil y mil gracias. No sé si quieras hacer un comentario final de cierre antes de despedir la sesión.
No, muchas gracias por la invitación y espero que continuemos esta discusión. Estos son temas candentes y tenemos que discutirlo desde la academia, tenemos que discutirlos como futuros profesionales y también como docentes que somos. Entonces, no, que sigamos en ese camino.
Muchísimas gracias a ti, José Fernando. Muchas gracias a las personas que se conectaron en esta mañana con nosotros en la plataforma virtual Teams de la UPB. Les recordamos que esta sesión va a quedar disponible en el canal YouTube Saludable también de la UPB. A todos, muchísimas gracias. Un feliz día, un fuerte abrazo, cuídense mucho y nos vemos en las próximas sesiones de las reuniones clínicas médicas de la Facultad de Medicina. Feliz día para todos, que estén muy bien. Muchas gracias.